Hello and welcome to today's AAHAM webinar, Price, Transparency, Nuance Review, and Roadmap to Compliance. I'd like to introduce your speaker for today, Caroline Znaniec, Managing Director in Healthcare Advisory at CohnReznick. Caroline, if you're ready, the floor is all yours.
Great, thank you so much. Hi, everyone. Thank you for attending today's webinar. Just to give you a quick background to why we're here, I think many of you obviously are not as excited as some, but some of us are, looking forward to getting past this price transparency mandate and the compliance deadline. With the new hospital price transparency requirements looking to be implemented January 1st, 2021, we've seen many providers that, largely due to the pandemic, have delayed their internal efforts towards the compliance date in hopes that there would either be a delay in implementation or enforcement that would be afforded to them to give them a little bit more time, if not change the requirements. So far, a delay has not been provided. The requirements themselves, have obviously shown to be complex, and they require a great deal of data to be inputted, extracted, analyzed, and published for across all different types of areas coming out of disparate systems. And with time drawing near, many of the hospitals worry, certainly they cannot meet the compliance deadline, or concerned that they do not fully understand what is needed to comply. So wherever you may be in your journey towards this compliance mandate and meeting the requirements, hopefully this webinar will give you some direction on how to get started, or based on the different phase that you may be in, give you a little bit more information on how to properly address the mandate, what is absolutely required, some benefits to actually seeing some value in the compliance. We'll talk about some of those pieces. But definitely understanding fully what you need to comply, because there has been a lot of questions related to diving into a lot of the requirements on exactly how to pull the information, how to pull it together, and then put it out there for the public display. So today we'll go through some guidance on regulatory nuances associated with that data extraction, again, the analysis, the publication of that piece, and share with you a roadmap to compliance that helps to outline the key steps and speak to some of the timing related to that roadmap and those activities. Again, keeping in mind that we have January 1st right around the corner. It's going to come up rather quickly. So I wanted to discuss on this slide just the highlights between the years prior and the requirements that we have now going, and then what we have going into 2021. So the pricing transparency requirements themselves really came out as part of the ACA, and really where we began was having the ability for our patients to ask if they could have that pricing information. Give them a method that they can contact your hospital and ask for patient estimates, understand what their out-of-pocket may be, and just the charging in general. And that was fairly easy. It wasn't until we came into the requirements that were implemented in 2019 and what we followed for this current calendar year, where we started to see a little bit more information and specifics related to what we have on a line item type basis. So we started really looking at just our charge master and putting that out there. And what came out from that requirement in 2019 was really CMS taking a look and saying, okay, maybe we weren't specific enough. So here we are in 2021 looking to get a little bit more specificity out of the information from the hospitals. When we look at our scope here, it's hospital and hospital employed providers. So that was a little bit of a shock for some folks to say, wait a minute, we weren't talking about hospital employed providers before. And what does that mean? What does it mean to be employed? And so CMS has taken a stance on that to leave that question to your legal department and what constitutes an employment contract. And so they still have stood by that piece, but it's really pulling in and understanding that detail. And as far as what is considered a hospital, it's a hospital by definition of who is licensed in your state and how the state defines a hospital for the purposes of licensure. The exclusion there was really those that were federal run. So we think about Veterans Administration, DOD, those hospitals are excluded. Everyone else comes into play. So critical access hospitals, children's hospitals, psychiatric, all different types, again, going back to that definition of your state. And then also looking at all chargeable items, services, and procedures. that we have in place. And the reason that came out and why they had to state that was because in the 2019 and a lot of what we're still seeing in this current calendar year was really just an extract of the charge master, but it didn't necessarily break down in further detail a lot of those items and services because perhaps they were in different systems and not necessarily in our standard charge master file. And so they broke apart in requiring also in the two file layouts, standard charge file and a shoppable services display. So our standard charges is more closely to what we relate to as a charge description master. Gives us the description of the service, what's our gross charge, what do we have as our default, and then what really came into scrutiny and what was the most controversial was providing payer negotiated rates. So understanding anyone that you had a negotiation with in contract, regardless of whether it was used in the last year or it represented one patient, as long as it's an active contract and negotiated, having to have that included. And understanding what the allowable rate under that contract was provided to the hospital. Doesn't mean necessarily that's what the payer paid you, but what's allowable. What I mean by that is something may be allowable to $100, and maybe there's a cost share from the patient. They want to understand what's the allowable piece, what you would see in a remittance type advice. And then also cash pay rates. So now we're getting into a different term as far as understanding what is the cash pay, what is the true amount. If I were to come in with a bundle of money, millions of dollars, I don't have to have insurance, I pay my own way, what would you charge me? So outside of any sliding fee scale, charity care, truly what is your cash pay rate? And so that was a different differentiator too. And all this information, if we're thinking about it, it's in a spreadsheet for the most part. It's line item. It's all of this different detail. So charge master, we're typically used to seeing our CDM number, our description, our revenue code, a CPT HCPCS, our charged amount, maybe a modifier, maybe a billable unit piece. But what's really blowing this out, if we think about it from the number of columns from left to right, is all of those payer negotiated rates. And for some hospitals we're working with, it's anywhere from 8 contracts to hundreds in that way. So understanding that they could be a very complex and large file to doing this. Probably the easiest piece out of this exercise is when we get to a payer negotiated rate, minimum and maximum. Calculating what is the minimum accepted from our payers that we negotiate with and what is our maximum piece. That's a more simpler calculation than all of the information having to be pulled together and put into this file. And then coding and billing identifiers. So thinking CPTs, HCPCS, could be NDCs for our pharmaceuticals. If we have payers that relate our payment or determine our payment solely on the basis of a revenue code, that is now a coding and billing identifier that you would need to include in there because that's what's identified for your payment for those payers that you may negotiate with. And so all of that information is pulled into, for our standard charge file, a single machine readable file. And that doesn't necessarily mean you can't have multiple tabs. If we think about machine readable file, a single file, think of an Excel workbook. There could be instances in how you have different rates as we look at packaged and bundled services, different types of requirements and considerations for different payers that don't necessarily line up easily with a charge master type layout and in our typical columns and rows. And so we have to want to carve them out and stick them into another tab. When they say in the single machine readable file, it doesn't mean everything has to be in one place. It's in that one file, but you can have it tabulated to have that information provided. So that's the standard charge file. The additional piece is the shoppable services display. And this is where it's really, if we're thinking about the objectives behind, at least what CMS is telling us, the objectives behind price transparency is to really be able to communicate with our consumers and our patients to give them an idea of this is what our charges are going to look like for your particular service or procedure. And based on your payer, is it a package payment? Is it a line item? And if it is a line item, what are those different line item services? So I always pick on hernia repair. If I'm scheduling a hernia repair, is my payer saying, regardless of how much time, supplies, pharmaceuticals, anything that's related to that care takes, I'm going to pay $5,000. Our shoppable services display would show $5,000 associated with the hernia repair, primary service, and CPT code and required information. Now, if I have a payer that pays percentage of charge related to all of the things that go into that care on that day, I now need to show, here's my primary service, and here's my related ancillaries, supplies, pharmacy, those different pieces. So it's really understanding, pulling information, not only from your standard charge file, but the compilation of that and the interrelated charges related to the primary service and how they're going to be received when they go to the payer and reimburse. And that's really what the shoppable services display is. It's 300 identified services, 70 of which come from CMS, 230 that you, the hospital, get to select yourself. If for some reason any of those 70 are not available at your hospital, you don't provide, you still must list them and indicate that they're not applicable, not provided, but you now have to fill that gap. So let's say you have 50 out of those 70. We're going to take that variance of the 20 that we don't provide that CMS has given, and now we don't have 230 of our own services to identify. We have 250. At the end of the day, it's a total of 300. And what they're looking for is to identify services, again, that are elective. They can be scheduled. They're likely those that have a higher volume. They could also be ones that you want to be known for in your particular market or may be competitive. Those are the different parameters around how to choose those. If you have hospital employed providers, it's not a list of 300 for the provider professional side and the 300 for the side of facility. It's all encompassing, including both. So you could have a mix in your 230 of professional services as well as technical services that can be combined. And so what needs to be shown from the shoppable services display is that primary service that you're identifying. Again, if there's ancillaries that go along, if it makes sense and is required of your payers, to identify that piece, and then provide your payer negotiated and cash pay rate related to that primary service. Also the minimum and maximum. One thing you won't see here is the requirement for the standard charge. That does not have to be included for the shoppable services display. One piece that is required that's not necessarily called out for the standard charge file is plain language. Again, thinking that the shoppable services display is more consumer patient facing than it is for the standard charge file. So let's take, for example, chest x-ray. For many of us on the phone, CXR, every day, all day long, a lot of us are going to say, oh, that's chest x-ray. Your layperson's not going to understand that, so spell it out and give them information related to that. This is not an exercise that necessarily requires you to go back and rename every single line item in your charge master. There is the ability to use AMA CPT code files and other files out there to be able to look up on primary code and provide a description that's more patient-friendly than what we may have related to our very much constrained charge master descriptions. If, say, for example, we have 30 to 60 characters, it becomes difficult to make those patient-friendly. On package services, so many of us may say, oh, well, we don't have bundled services at our hospital. Many of you do, and it comes on the inpatient side. So whether it's inpatient or outpatient, package services have to be part of your standard charge file, as well as they could be part of your shoppable services. So in a standard charge file, if you're being reimbursed for inpatient services at a DRG level, then that's your package service. And that may be one of those opportunities for when I was calling out that single machine readable file, separate tabs, that could be a separate tab on your DRGs. That applies regardless of whether you're a PPS hospital or non-PPS hospital in providing that information. The median DRG negotiated rates in the Medicare cost report, that is now required only of PPS hospitals. So if I am a critical access hospital, a Maryland hospital, I do not have to provide for the federal mandate a median DRG negotiated rate for my Medicare Advantage payers in the Medicare cost report. This is for those hospitals that are under a PPS payment system that are applicable to the inpatient prospective payment system's final rule. The format and location. The machine readable, we talked about that for the standard charge file. Again, it doesn't necessarily mean a single tab. If you think of it from Excel, which is the majority of what we're using, and seeing out there for those that are going through this process themselves, it needs to be easily accessible, and that's either one. That's either standard charge or the shoppable services display. It has to be easily accessible. We had in the prior final rules for 19 and then what carried over into 20, some hospitals that purposely hid their charge masters out of sight or made it difficult to find, didn't make it very consumer friendly. And so CMS, again, it's one of those things they picked up on and said, hey guys, you got to make this easily accessible. It needs to be available to the public. You need to call it out really quickly. Anyone should be able to find it. So it needs to be prominently available online. Digitally searchable. So if I'm looking for a charge on a chest x-ray, or I'm looking for a certain lab test, maybe I'm looking by CPT code, I need to be able to find that information. And that's on both files. That's the standard charge file and the shoppable services display. So while we're talking about plain language on the shoppable services, truly to make the standard charge file usable for the consumer, now we can argue and debate, now is the consumer of the standard charge file a patient? Is it an insurance company? Is it the media? Is it consultants? It truly could be anyone, but to make it digitally searchable, we really have to clarify those descriptions as well. But we have additional identifiers in there that you could argue that could find a certain service if somebody had that information. CMS naming convention, this is one a lot of people have missed, is there's a certain file path and layout to saving those files on your website. So if someone were to be able, against machine readable, you can export it, you can download more for the standard charge file, that there's a certain naming convention that's in place. And if anyone has a question on exactly what that is, send me an email. I will send you information related to that. The maintenance hasn't changed much. Only it's expected that this is going to be updated on an annual basis. That doesn't mean January 1st of every year. If you're ready to go and have this file ready by the mid-December or even tomorrow, go ahead and publish it. And then your annual clock will start. It doesn't necessarily mean January 1. It's a little loophole there, as some folks were waiting for the 2021 CPT code updates. There's nothing that indicates in black and white that if I publish for mid-October, that it's expected that the 2021 CPT code information is going to be there the current year. It's implied, but not a requirement. So if you feel like you're ready to go ahead and don't want to wait till December 31st and rather enjoy your New Year's Eve, go ahead and publish it. And just know that you have until the next time, and here we are at the end of October to be able to go ahead and update that in the next year. One thing, they want a date stamp. They want to see the date of the last update. So they want to be able to have something, if you're putting your auditor hat on, that they can go back and say, yes, this is when it was last updated. Or if somebody's scrutinizing that maybe the codes aren't up to date or rates have changed in the meantime, you can say, well, at this snapshot in time, this is what we were looking at. So it helps you from a audit defense standpoint, as well as letting people know that there could be some time and some differences in place there. So one of the biggest questions I get related to all of these requirements is, definitely it's a lot. It's a lot of information, and we're going to talk through in the roadmap and some further slides of, how to pull all of this together. But is there going to be a delay? So I would say at this point, likely there's not one in sight right now. I don't see it coming. If you haven't seen, there was an executive order at the end of September. It's in support of the Trump administration's America First healthcare plan. And in the executive order, it was the end of September, I believe it's the 24th, it addressed surprise billing as well as price transparency. We were hopeful that, understanding that we knew an executive order was coming out, hopeful that it would at least delay the timing related to this mandate, and it just further confirmed CMS's as well as the Trump administration's want to have transparency and to make it happen. So what you will see in that executive order is them restating the importance of transparency and the requirement that is coming forth January 1. Outside of that, there was others that continue to delay their efforts towards meeting the mandate because there was a hearing coming up in it was mid-October, October 15th, where it was going to a federal court to argue with AHA as well as some other supporters to indicate that they still did not feel the payer negotiated rates were in CMS's authority, but also asking for some delay and some time to be able to get this information together. Obviously, COVID was on their mind, as well as hospitals looking to see what actions were going to come out of the lawsuit. So there hasn't been a ruling coming out of that. It was heard. There's likely not going to be anything additional based on the feedback that's come out of that discussion from the judges that were there, indicating that they really didn't see what the hubbub was about, why it was so difficult, and this is the way the industry is going. So really coming out of that, full speed ahead, we're still looking to go forward. So for anybody that's still holding out, I would say we're getting slim on time, and the likelihood that we're going to see a delay or any drastic changes to what needs to be reviewed, regardless of even the presidential election, I would continue to move forward with understanding that January 1st mandate is still in place. Both sides are looking for transparency and changes in pricing, and this is one of the foundational items that is continuously called out. So what I want to do now is going into these next few slides is go through some price transparency, nuances, and myths debunked. And some of these I've touched on, but we'll go in a little bit more detail into these following slides. So the first one here, hospitals that provide for an internet-based estimation tool are excluded from having to publish the standard charge file. This is not true. This is a myth that we've heard. When we talk about the shoppable services display, one option for hospitals that have an existing patient estimation tool, and I know there are some hospitals out there that are in the process even now of implementing a patient estimation tool, is that if they have that, they're excluded from the shoppable services display. They don't have to otherwise put that out on their website if they can direct patients to the estimation tool. You still have to have that standard charge file, that big, enormous, machine-readable file with all of the detailed information. You still have to go through that process and have that ready to go. And even if you have a patient estimation tool, it's not as simple as saying, yep, I have a tool, I'm going to check that box. There's still requirements related to what has to be included in the tool and how it's going to be utilized by the public. It still needs to be, because some estimation tools are very specific to your clientele and your patients that require a login and password. It cannot be gated in that way. It has to be publicly available as an estimation tool. Now, you can require someone to log in to give some level of PHI and information related to their insurance if you want to get to a certain level of out-of-pocket expectation. But in order to at least get an estimate based on the shoppable services amount related to the charges and the estimate of what the allowable is, that needs to be open to the public. That cannot be gated. The out-of-pocket portion of your estimation tool, that can require additional information to get a better idea of co-pays, deductibles, any cost-sharing requirements. And even so, in the estimation tool is making sure, again, those 300 shoppable services are there, and it's indicating all of the different elements. And CMS has done a fairly good job of explaining what those different elements are, both in the final rule, as well as if any of you have listened to our webinar before, one of the biggest pieces of information that I go back to and reference was a Medicare Learning Network call that was in the end of 2019. There's a presentation, a transcript, great information came out of that phone call that really spoke to a little bit more of these nuances and gave some direction. As well, CMS has come out with some great information, FAQs, more recent than not, giving a little bit more of that detail really to what is expected as people are starting to use and move towards the estimation tools. Estimation tools really are something that's really a decision at the hospital level. And if they don't already have an estimation tool, if you're looking at one, to consider. It's not something I would rush into. They can be costly, depending on which one you use. It requires integration. A lot of the information, the steps that you have to go through to get the standard charge file is very similar to what you'll need to be able to integrate the patient estimation tool. And right now, we have some hospitals that are kind of on the fence about whether or not to invest in the estimation tool right now, not saying it won't be something in the next budget period, but looking to see really what that ROI is. So if you're looking at estimation tools, really start to look, how many times do I get someone to ask me for an estimation? How many times do people come and look at our website now for charges? And you may be surprised that there's some hospitals that get a lot of traffic, there's some that get none, that have been tracking this for the last couple of years. But the industry as a whole is moving that way to be more transparent on out-of-pocket. I'm not trying to convince you not to have an estimation tool, but I know there's a lot of budget constraints out there right now related to COVID and different pieces. It's just something to consider if it's something we need to purchase now or potentially purchase later. Our next myth, the standard charge file only includes those individual line items found in the hospital's standard charge description CDM export. This one's a big one because I've heard varying opinions on the translation of the charge master and what CMS means versus how we see that as an industry. So as a consultant, and I've done charge masters for a number of years, one of the first things if I'm doing a charge master review, even today, is to ask someone, I need to have an export of your charge description file. But if I know if you work with certain technologies that if I just ask you, and I'm gonna pick on an EHR, I have no favorites, but if you're an Epic facility and I come to you and say, I want an export of your EAP, I already know that I'm not gonna get the detail necessarily. For pharmacy, I need to get that out of Willow. I may not get your HCPCS detail and understand what's being mapped to that without looking at your item master and understanding what your markup tables may be if it's not sitting in more of a static CDM type layout. It's those dynamic CDMs where we have to pull information from different modules. There's different behind the scenes markups, different algorithms, different rules in place. That makes this a bit more complex. When CMS is speaking about taking a look at the charge master, they're not thinking about that as a type of file that's being exported, but more, what is your master of charges? Think about it in reverse. They want all items, services, procedures identified in the file. And if you strictly just take your charge master, you're not going to see that because you have time-based services. You may have anything that's soft-coded. You have categories, potentially. You have shells. So we need to break it out a little bit more detailed because a lot of that information that may be flowing through the charge master, but really the output as far as what's a billing identifier and how it's recognized for reimbursement from your payers might not sit in that standard charge master file. So we need to go a little bit more past that. And case in point, DRGs. We don't keep DRGs in our charge master file. And it's called out by CMS consistently of having to put your bundled payments in there, and that includes your DRGs, as we're talking about bundled payments and payment rates. So probably an issue of debate depending on who you talk to, but that's my interpretation of how I've read CMS is to have that information available. It's not, you got to go past your standard charge master export. Going on to the next one. Hospitals that have bundled payment arrangements with payers only need to display the bundled payment rates in the identified shoppable services display. This is a myth too, as I was talking to DRG as an example, need to be in your standard charge file, as well as if you have bundled services related to, most commonly we see cardiology and orthopedics needing to have that called out. And how you go about doing that, it will be very specific to the individual hospital, as you may have, let's say for an example, bundle payment related to a pacemaker insert, which is going to include your implants, any other related supplies, whether it's a catheter, guide wire, sheaths, all those different things. If you had prep time, recovery time, anesthesia time, anything that you would have itemized and charged out separately, radiology, all of that. And it's just going back to the primary service. So our CPT code that's coming through, some are hard-coded in the charge master, others use time-based services, or maybe soft-coded flat fee reimbursement. How that's going to be displayed in the standard charge file is going to differ based on, again, your charge capture methodology and how your payer reimburses that piece. But it needs to be clear in the file to be able to recognize that. So again, bundled payments, I think that's the biggest piece right now as far as some confusion as people are starting to get really in the weeds of how to get information as they're looking at the payer contracts to make sense in more of a spreadsheet type format. These are the types of questions and nuances that come about and what needs to be included. It's not that I look at the payer contract and say, yep, there's CPT code 332 whatever for my pacemaker insert. I get paid $25,000. I look at my charge master and say, you know what? I don't have that hard coded. I move on to the next one. No, you need to figure out in the reverse how to put that into your standard charge file. So it goes both ways. We're starting from our charge masters. That's a good place to start, but then it's also in reverse. What are we getting reimbursed for? What's in our contract? And do we have that listed in our standard charge file? Again, going past just looking at it as a charge master exercise. In calculating the minimum and maximum amounts for the standard charge file and shoppable services display, traditional fee-for-service Medicare and Medicaid are included in the calculation. This is, again, false. The minimum and maximum is for your payer-negotiated rates. And it's not just for traditional fee-for-service Medicare and Medicaid. If you have other payers and maybe related to a specialty carve-out type service, maybe it's psychiatry type services, if that's available to the public on someone's website, if I were to have that insurance plan that covers for my psychiatric benefit, and it's out there on public display, I don't have to include that on my file. It's only those that truly are not available to the public's eye and are payer negotiated. And then from that amount is where my minimum and maximum comes from. It excludes my cash pay rates, and again, anything that's not payer negotiated. So those are excluded. Some hospitals would like to put in the Medicare and Medicaid rates for public display. That's of their choosing. If you do so, at least from the compliance requirement, again, it doesn't include those because they're not considered payer negotiated. So just keeping that in mind going forward. And then our last kind of myth here, in displaying a shoppable service, only the primary service itself is required to be displayed along with the standard charge, cash pay rate, and negotiated payer rate. So this is a two-part myth. In displaying the shoppable service, we think about the primary service. I'll give the example of the hernia repair again. It's true that you only have to show the cash pay rate and the negotiated payer rates for the primary service if the payer that you're calling out treats that as a bundled service. So if I'm getting a set amount regardless of any of the ancillary services timing involved with that hernia repair, I don't have to show all the related detail. You also don't show the standard charge in the shoppable service file, so that's part of that second myth. Now again, if your payers are looking at, if you have a hernia repair and you also have, I don't know, maybe an abdominal ultrasound, or you have other supplies, pharmacy that's indicated there, and they're going to pay those separately outside of the hernia repair. And those are standard type charges that you typically see with your average patients, then you itemize those out. And you have to show, again, the information related to that, whether it's cash pay rate and negotiated payer rate. And that is, again, primarily driven by your payer contracts. And so if you have a mix, and I think many of you do, we've seen hospitals that are just straight percent of charge, that's a much easier exercise than it is those that have a mix of percent of charge, fee schedule, bundled payments, and different types of carve-outs. That's when the complexities come in, is when you're getting away from standard fee schedules or percent of charge and have these more complicated reimbursement methodologies. So I'm going to move on these next few slides to talk through really building upon the process for how do we go through addressing price transparency and getting to be compliant with our mandate, again, coming January 1st. So the first step is understanding, who are all of my stakeholders? And I left the stakeholders more so to internal stakeholders, understanding also that we have our community, we have our patients, we have our payers. This is more so, who do I need to look at internally to be able to get this process done and so we can meet the compliance piece of it. So who we have here, we have revenue integrity, and could be CDM, and I have different verbiage. It's more function than it is title at this point, but who's going to be available to get us the correct files? Who's going to be able to say, yes, we have charges here in our charge master. We might have them sitting in our formulary. We might have them sitting in an item master. We might have some behind the scenes algorithms and data tables that are pulling in with some different logic and rules in place. That's primarily going to sit with revenue integrity and CDM for most facilities. And then compliance and legal, these are the folks that are going to help us determine who's in scope, what facilities are included under the hospital, what services, what providers, who truly is employed, and how do we need to get those folks identified, working with the CDM, revenue integrity group, to understand where those fee schedules may sit and where their charges are coming from to pull that together. And then reimbursement and managed care, providing the information related to the payers, definitely keeping them close at hand because sometimes those reimbursement terms are outdated. You may be surprised to find as you're pulling this information that the last time you had a fee schedule update was 5 years ago, but you know that they're paying you to a more recent fee schedule, having to ask for that, getting reimbursement managed care involved to identify, to pull that information together, as well as help you translate, because they likely have a payer representative they can get a hold of quicker than most to be able to answer questions related to reimbursement. Clinical operations. They're good to have in place because we're starting to understand just the charge capture component as well as looking at the pricing, if there should be any question. This comes more later on to talk about the value and compliance. Is as you're going through this exercise, you're going to find some opportunities to tighten up maybe some controls, better identify some of the chargeable services. Clinical operations should be involved in that component and understanding where this information is coming from, what it looks like, and be prepared as well if there's going to be questions from the patients later on how something is costed out for them, with how the charges work in relation to their plan of care. It's good to have your clinical comrades ready there for you in support of the process so they can explain it later on. Revenue cycle and analytics, it's your business analytics, your decision support, whomever may be able to have their hands into claims level detail information. These are people that can help you identify shoppable services, median charges, really starting to pull that information together even into your format and display and what you're deciding on moving forward. Information technology is helping with the access, pulling information together, looking at putting the content online, making it publicly accessible. Great stakeholders, obviously, to have there. And then marketing and public relations. Sometimes we don't think about them until it's absolutely critical. This is something that I think all of us can agree. It's going to be very complex to explain to our consumers and our patients on this is how the information comes across. Healthcare charging and pricing and reimbursement is very complex. So working with marketing and public relations on the narrative to put on your website, the direction you're going to give the public, and what is your messaging, and how does it align, for example, to the missions and values of your hospital, and what are you doing in your efforts, not only to comply, but maybe even take this as an opportunity to understand, what the community needs. Maybe this gave us an opportunity to look at our cash pay and uninsured discount program. And so, trying to play from that side too, in an honest way of how this exercise has maybe brought attention to the need and identifying, coming out of COVID. This is also a great piece for us. There's so many different angles, and marketing and public relations should be part of that conversation. So what you have on screen and what we're looking at here is a roadmap that we've created for ourselves and our clients. And when we think about all of these different pieces, just looking at this from a visual, and there's a reason and flow to this, the color, and we're going to hit each one of these different points and these milestones along the way. But just to give you an idea, as we're talking about a project roadmap, it's going to be more of a strategic plan. It's going to explain our goals. It's going to set out our major points that need to be accomplished and really what we're trying to get to in order to meet the mandate. It's going to be more of a guide. Again, it's high level, it's overarching, but it's definitely something this is something that needs to be looked at with more of the eyes of a project. It's not something that can be done in a silo. Again, we talked about those different stakeholders and the involvement. So this really starts first with the starting point, and you see that gray rectangle. This is our starting point that's called out there. This is going to be more of our kickoff meeting. And so a lot of the time the questions, well, who do we have at the kickoff meeting? Those are the stakeholders that we're talking about. Bring those stakeholders to the table. And if you're treating this as a project and your project roadmap, you need to identify who is your main point of contact. Who's your project manager? Who's your sponsor of this project? And that can vary. It could be, compliance could be leading the charge, finance, revenue cycle. As long as it gets done at the end of the day, I'm not going to argue who owns what. As long as you have this laid out, everybody's on the same page, and you understand what is your scope, what are our milestones, how are we going to talk to one another and make sure that we stay on track and we're being accountable. What data do we need? Again, who's owning it? Who's accountable for which pieces? And really laying out the different tasks and assignments by stakeholder and how they interrelate to each other. This is not a project, again, that's going to sit and be very well done, everybody doing silos and handoffs. And what this picture is to show you is you can see it's close to the far right, format and display. This is where, the final piece of how are we going to message? How are we going to put this on our website? What's it going to look like? You're starting day one having those conversations. And so that's why you see it in blue. It's going all the way through our milestones. And then you can see after data extraction, you have data translation and data analytics. The reason why there's two colors there is because these can be done simultaneously. So that's really kind of the visual representation here of our roadmap and those individual steps. So our first piece, data extraction. So definitely after our kickoff, we have already identified, and I would go to the kickoff meeting with this list to be able to understand what is going to be expected of those stakeholders, because this is a time with the stakeholders in place to say, okay, this is where we're at least going to start with our data assets, what we need to, and you see here, identify, compile, and verify. Because we always want to make sure that we're verifying that we're getting the right information from the right places. So having that stakeholder communication and having everyone at the table go through the data assets will help to understand and save you time later. So come to the table with your list of data assets. So we're going to start with CDM. Where does the CDM relate to the fee schedules? Because again, if we have dynamic charge masters, our fee schedule does not necessarily now sit in our CDM like it used to in our static CDMs with older technologies. Do we have information or ancillary modules? Again, I called out the formulary, the item master, different areas. Claims level, captured and billed data. This is going to be helpful in further steps. Our contracts, understanding what our pricing methodology and policy is. And you might think, well, why do we need that if we're pulling information together? Charges are charge. Because as you're starting to pull this information together, and it's really that value proposition, you might start to see something that looks a little odd and inconsistencies, whether it's a price over a contracted amount, or it's prices, my bilateral services are priced lower than my unilateral. Why did that happen? And being able to reference that policy as you're going along. CPT, HCPCS, and DRG procedural dictionaries. That's information to be able to have at hand. If you have a license with AMA, which many of you do, either directly or through, maybe it's your 3M or other billing and coding softwares, AMA has been putting out a patient-friendly descriptions file for CPTs for the last few years, and it should be part of your license data files. That will help you with that plain language friendly descriptions that you may need to be able to pull into your different information, and as well as the DRG procedural dictionaries. HCPCS is available publicly online through CMS's website. Be able to have that information together saves you time keying anytime you have to come in to do that piece. So data extraction, again, identifying what we need, where we're going to get it. It's going to vary by hospital depending on if you have a static CDM, a dynamic CDM, where information and rules may reside, understanding where all of these different components come into. And again, having that stakeholder communication, having them at the table, you may get someone that says, well, wait a minute, you don't want to pull that information from here, because really what ends up coming out to the claim happens in this little black box process later on. Is understand, are you pulling the right data from the right places, and later on being able to verify and validate that with some other component. And this is one of those other components. So you'll see here data translation. The next slide, we're going to talk about data analytics, but visually just letting you know, this is really where we start to have simultaneous tasks and where we can have some time saving. So as we're talking about the roadmap to compliance and understanding, can we still make it by January 1? Yes. However, I say yes if you have the dedicated staff to do this and being able to separate. If you have the same person pulling together the data, translating the data, analyzing it, and then also speaking to IT and marketing, it's going to be tough to get that done. But likely you can have some people within your organization doing similar and complementary tasks to get this done. Some have had to go outside to get assistance. Others are taking a step back and saying, well, I can only get this far, and working their best to get there. But the data translation is where we're taking that information from the data assets list and starting to pull it together. So data translation at this point, and you can even start, your data translation team could even start from the kickoff, starting to pull together the template of how this information is going to look. So if we think about the standard charge file, there's not a discrete and required template from CMS. Now, there's direction from CMS and some examples of how they view that file looking, but it is not a required template. To me, that's going to be more of a phase 3 coming out of this. In the next couple of years, I can see them having required reporting templates and different mapping tables, that type of thing. But right now, we don't have that. So the group that's pulling this information together, either is separately going to create that template, or you'll find as they're starting to pull that information together, it builds itself, honestly, based on your facility and how your contracts look and how you're pulling that information in to align it, as well as validate it across your stakeholders. It's really starting to format that template. And we're going to start with our standard charge file to get a lot of that information together in this step. So it's taking that CDM and module mapping. So if we're having to detail out, for example, a shell or category CDM line item and break it down to the greatest detail, it's knowing how we're pulling that in from the modules. Identifying the chargeable items, services, and procedures that we want to include. So if you think about looking at your usage statistics, for example, if you have items that you have not used and they have 0 usage for the last 12 months, 18 months, however you want to do that cutoff, if you haven't used them, they're not going to be in your claims data. They're not going to be sought out necessarily by patients right away. Save yourself some time and energy, take those line items off. Identify truly what are you going to include. Phase 3, cardiac rehab. If that's a cash pay service, it's not something that's going to hit your cost report. It's not going to your payers. It shouldn't be something Medicare is looking for. That's more of a cash pay service. I would take that out. Understanding your different code sets. This is one that, we talk about, are we looking at a snapshot in time right now as our revenue integrity CDM group, maybe looking to update the CDM and our order mappings and our tools, our charge capture tools to the 2021 code set. Are we waiting for them, or what are we going with? So understand where you are with your code sets, if you have to translate that later, or if we're going to be looking at this right now. So it's understanding that data translation. What naming conventions are we going to have? Are we going to pull in our patient-friendly naming convention as we're pulling this information together? Our payer terms, our data integrity, and what is meant by that is, as you're building this, have some checkpoints, again, with those different stakeholders to say, does this look right? And during that data translation, your biggest stakeholder there is definitely going to be managed care and reimbursement. Make sure that as you're looking at your payer contracts, you're appropriately pulling in that information, and then we can validate that and verify that with our data analytics group as they may look at claims detail and different pieces, just to be able to do that double check. But understanding what certain terms mean, if you don't have people helping with this particular task that sit in managed care or well-versed in those contracts, but more so, have analysts in there just inputting away and translating it in to the file, have that extra oversight to make sure that they're translating the information appropriately. So what can happen simultaneously with the data translation team as they're pulling that information together, and they're more doing that mapping activity, very detailed, probably a little bit of boring work, they're translating it and keying in and pulling information. As data analytics is going, and that's for the standards, they're going to start with the standard charge file, is the data analytics group is going to start working on a shoppable services display. And so the first step there is going to be identifying what that template's going to look like. Are we going to have a file itself? They also can help with the data translation team and that standard charge template, but also understanding from the data analytics, do we have a patient estimation tool, which we should already know by then? Let's say we don't, or either way, we have to identify our shoppable services. And again, it could be that 230, or it could be the 250 example I gave you, because maybe 20 of those 70 that CMS pointed out, we don't provide, and we have to fill that gap. So we have 300 at the end of the day. The data analytics group is going to help to identify those using some definitions and discussions that we have during the kickoff meeting. It's how do we best want to do this? We want to do this by volume. We want to do it by what's competitive, understanding what services are scheduled versus emergent. So you don't want to show up and say, oh, well, we have high volume of level 3 ED visits. Well, that's not elective. So got to be a little smart in our analytics and our approach to how we identify them. They're going to help us reconcile the data assets to those templates, both in the standard charge file and shoppable services. So testing a bit as we're looking at taking the payer reimbursement terms and applying it by a line item. Is that truly what we're seeing in our allowables coming out of our claims information and our rebits? Just doing some testing there to make sure that we're aligned in that way. And then calculating that min and maximum and medium, again, one of the easier steps. And then making also sure that we have some data integrity. So a good example there is let's go to our claims level detail that we have CPT codes associated with, and we look at to say, here's our unique list of all the CPT codes that we filled out in the last, again, 12, 18 months. Do we have those reflected in our standard charge file? So doing some reconciliation that way too, and being able to fill the gaps. This is really where those data analytic skills come into play. And they're going to work directly with the data translation teams. Your data translation team at the end of the day should own what the detail is in those particular files. The data analytics group is going to help you more determine if that information is appropriate, help fill those gaps, and do that reconciliation. And again, working side by side simultaneously together. Not necessarily one step requires another. There's a lot of work, again, can be done at the same time, especially as we're looking at our sensitivity and timing going forward. That will be of utmost importance. And then the last piece is that format and display. It's really understanding more of the consumer-facing format and display. What is that going to look like when I go to the website? And so these are conversations that can happen along the way. One thing I've learned through the years of working with IT is go to them first and say, here's my compliance date. When do you need this information? Because they have their own process for validating and testing and taking it to different stakeholders. So it's more so they're going to set a little bit of a timeline for you working backwards off the mandate than you coming to them and saying, okay, I'm going to give this to you a week ahead of time, or I'm going to give this to you on the 30th and going forward. So have that timing conversation. Day one, at the kickoff, what is the timing? How are we going to get there? Letting them know what's required. And we can start also with marketing and public relations related to what instruction we want to give our consumers. What disclaimers do we want to put out there? For example, this is an estimate, not a guarantee. I've been instructing the marketing and PR folks to have something in there to say, this file layout and the information is required of us for the federal mandate. We identify that healthcare can be confusing, it can be complex, has a lot of variables. We would love to help you. Please pick up the phone and call us. That's always, if we're looking at the objectives behind what CMS is trying to get to, if we're really truly doing this for the consumer, it's better to direct them to someone that can really understand their particular individual requirements, what they're looking for, and give them a better option there than trying to lead them to their own ways online and create additional confusion. And it's just a good customer service piece to have too. So putting all this together, so we're revisiting our map and going through, you can still do this and be in compliance by January 1. But your key strategies is, again, identifying your stakeholders, identifying what information needs to be had, putting some dates attached to this. Likely I would start from IT, work back, and getting to those different places. And that'll let you know if we have to have information to them by mid-December and we're not getting started until next week, and we're working back, it'll be very clear to you if you need external assistance, if you need to pull people off of different projects internally, what other considerations need to be in place in order for you to make those mandates and get that moving. You don't want to work necessarily in reverse and then come up to the last day and then IT say, I need 2 weeks to put this on the website. That would be a difficult place to be. So another strategy, you need to have dedicated teams. It's not going to be a good thing to do it part-time. When I get to it, that's just not going to work. You have to have that behind you, getting all of the buy-in from the executive group and obviously the momentum behind you, because we're also coming into November, we're going to be coming into holidays. With Thanksgiving, we've got Christmas, we've got New Year's, all of that needs to be played in as well. We also have some folks that really have been working hard through COVID, that if it's maybe slowing down at your facilities, I've seen some hospitals that said, okay, well, now we're going to let people take some additional time off in November, or maybe they're taking it extra week over top of Christmas. That needs to be considered too. So understand you've identified their availability related to this timing. Okay, and then finding value in compliance. One of the best things coming out of this, because I know a lot of people is just cringy to have to even think about pulling all this information together. It's just mind-numbing kind of work, and it's really hard to say. I see the benefit of this right now. The benefit in pulling all of this information together for many hospitals is we've never had to do that before. Necessarily in the format where we've visually been able to compare, here is our standard charge, here is our cash pay, here is what we are across our payers, because you may find as you're going through that and understanding how our payers are identifying and paying for our services in comparison to our pricing methodology, our charge capture methodology. So if we're thinking flat rate, time-based, what type of timing? Are we doing per minute? Are we doing it by time segment? Are we leveling our OR? Does it make sense compared to how our payers are paying us? Are we making it simple enough for us to administer and make it more efficient in maintaining our charge master, our charge capture tools, all of those related workflows? You may find there's some opportunity there for simplification along the way, as well as you may find some opportunities, not necessarily if you have a deleted CPT code, but maybe you don't have the best CPT code associated as you're starting to line up services, or you may find there's some that are missing. For example, you may have a gap in, I've seen this before in the wound care clinic where, it's based by size, but for some reason I missed that middle size gap CPT code. So it's really starting, you're looking at it from a different perspective, and it's the same information you probably looked at month over month, year over year in different segments, but when pulling it all together, it just opens your eyes up in a different way. Pricing inconsistencies, you may find you're below a payer. To have an opportunity to do that if you don't have a contract management software that does that for you. Many contract management softwares, even with some of our larger health systems, don't have 100% of contracts loaded. And the contracts that are loaded, maybe it's their top payers and it's the top percentage of services that are provided. So this is taking us to 100% of everything to be able to look at. So you may find those that are below payer terms. You may find more intensive services priced lesser than the others. So maybe we have a 4-view X-ray that's charged less than our 1-view. Just some inconsistencies to look at in comparison. And then one of the biggest pieces, and I don't want to come across too preachy, but definitely coming out of COVID, there's a lot of consumer trust that we're trying to build to get people back into our hospitals. And there's been some bad media on pricing and charging strategies that have come to light, not just out of COVID, but just in general. With CMS pushing the price transparency, the Trump administration backing all of that piece and pushing forward too. It's just really shining a light on the hospitals. So there's some hospitals out there that are saying, I'm not going to comply. I'll wait for the fine. Well, you will be publicly shamed if you found out by CMS on the Hospital Compare website. And one of the things that the industry is moving towards is aligning cost and value. So you have your charges versus quality. So putting this information out on Hospital Compare, this really could affect your score related to cost effectiveness and quality. So it's something to consider, as well as if you're a consumer and let's say you go to your hospital's website and you can't find the information, many people would be very critical to say, what are they trying to hide? So this is an opportunity, again, find that value in compliance to maintain that consumer trust. And to me, it's okay as a consumer, and I think even as a revenue cycle professional, as many of you, is to put it out there that this information is out there as part of a federal mandate. And if you don't agree that it's in the objectives, you can state that. And that's where marketing, puts the niceties around it. Say, this information's out there. It's very complex. Please pick up the phone and call us, and we can better explain it to you, because every patient, every payer, every scenario is potentially going to be different, and we get that, and we want to help you through this. So this is just a way, to help maintain that consumer trust moving forward. So that was the end of the presentation. I see we have one question, but I definitely, wanted to open up. We have until 3 o'clock if there's any questions related to the specifics. I see here we have one question, and I'm going to go ahead and just go through this one. It says, how do we publish our pricing for the inpatient rehab facility? How do we post the CMG code pricing? So this is something that, if we're looking at the CMG code pricing, if we're looking at any type of bundle payments, we may have to go for the single machine readable file, because you still have those individual items that you're capturing. If someone were to come in, if you have payers that identify any of those individual services for reimbursement, whether it's through a hospital employee provider or individually from the facility standpoint, they still want to have that information by line item. When it comes to any type of bundled payments, whether it's a CMG, it's a DRG, if you want to have that on a separate tab, that's likely your best way to be able to address that piece of it. So it's a little extra step. the next question, if a hospital has purchased a solution and it's not quite up and running by January 1, is that okay? So there's different opinions on that in different directions. So I will tell you, in the executive order from President Trump, and that was the end of September, he provides a direction to the department, the Secretary of Department of Health and Human Services, to begin to audit providers for compliance and report back by the end of March. It was 180 days from the executive order, which puts us towards the end of March, on who is not compliant, and that would be reported on the Hospital Compare website. So that's where that direction had come from. So if it's not okay, they're going to identify that. Now, I can tell you that I have not seen anything from CMS or HHS, any of those, as far as the absolute direction of who's going to do the audits, how they're going to do the audits, how are they going to score the risk, identify who's compliant versus not, how are they going to weight that, all of the things that you typically would need in order to audit and assess a civil monetary penalty may be in the works, but we have not seen any of that direction come out publicly. We've also, I'd say from a firm perspective, we have a federal contracting arm of our consulting firm, and they've tried to ask those same questions. We haven't gotten any places back to there. So I would say, are you going to be compliant? No, you run a risk of the monetary penalty, which can be assessed at $300 a day. What's interesting with the $300 a day, if you look into the detail of that, it's not really there other than to say that's the most that can be assessed per day. So it's implying that certain components would be weighted higher than others. What exactly those are, again, we don't have in black and white. There's a lot of unknown. If I put my compliance hat on, as an ex-compliance officer, I would say make your best effort. Be prepared that if you are identified, and they would have to, once CMS identifies you as not being compliant, they're going to submit a corrective action plan for you, is to be able to say, not say, wait for that corrective action plan and pick it up and keep going. Be able to show your efforts that have been ongoing and being able to support the reasons why you may not have been ready for January 1 to be able to react to that corrective action plan. So depending on how stringent you are on the compliance, you won't be compliant, but are you okay? The enforcement of this may be, left to CMS to say, maybe we're not going to enforce this right away, or they'll be a little bit more passive about it. But looking at that executive order, it looks like there's going to be a team out there looking to audit. Now, again, specific to what? Is it on something on the website? Yes, no type of audit, or are they getting into the different components? That would be difficult to see at this point. How would we go about finding a company to partner with to which to make this easier? So there's different levels of partners. There's different vendors that are out there. If you're looking to find price estimation tools, there's plenty of folks that are out there with different varying capabilities. I will tell you, there's some companies out there that are making it just good enough, and some that are going full 100% compliant. There's some that have the full solution versus others that may just have the estimation tool, not the standard charge file. There's a lot of different folks out there. I would say, if you want to email me and are interested in understanding what different companies are out there, or at least from what I'm hearing, I can't endorse obviously any one over the other, but there are some varying people that you can partner with. There's others that obviously are doing it internally with some minor assistance, either from a vendor partner or consulting partner, to get what they need right away, and getting the requirements out there. Might not be in a fancy tool at this point, but because of budget constraints, they're getting what they can out there to meet the compliance requirements. And those are ones that are going to have more of the standard charge file, and then the shoppable services display apps and an estimation tool. Another question, didn't they change it from the $300 a day to having the FI stop paying you entirely? That's a great myth that we've heard as well. So so now I get to put my legal compliance hat on. On the standard charge file, so for PPS hospitals, your risk is both a $300 a day, up to a $300 a day penalty for not complying with the standard charge file and the shoppable services display. If you don't have those up and going to the requirements, that's your $300 a day fine. And right now, that's all they can do. They cannot stop your payments related to that. Where the portion related to stopping your payments comes in, that's actually found in the inpatient prospective payment rule. So for your PPS hospitals, if you do not comply with the Medicare cost report requirement of publishing your median average or median DRG rates for your Medicare Advantage payers in your cost report, because that can actually result in your payments being ceased, because the difference there from the legal standpoint is the requirement for the Medicare cost report. That information is going to be used for future rate setting. And it says in the SSA that if you are asked to provide information related to future rate setting and you do not comply, that the Medicare contractors can stop your payments because they can't reconcile your cost report for future payments and rate setting. The reason why that doesn't apply to the standard charge file and the shoppable services display right now, because it's more of truly a display and informational. That information is not indicated in the final rule to be used for future rate setting. At any point, if that changes, if they're trying to gather that information to set, for example, like they are doing for the inpatient prospective payment system, they want to use that information for market-based payment strategies. If they take the same information from the standard charge file and shoppable services display in future rate settings, then they could potentially, if you don't comply, do that, but that's not the intent right now. So if you comply, if you're a PPS hospital and you comply with the Medicare cost report and don't comply with the standard charge file and shoppable services display, the most you would be is about $300 a day. And then if you did comply with shoppable services and standard charge and didn't comply with the cost report, you would just be potentially looking at your Medicare payments being ceased. Now, with the Medicare, in the Medicare cost report, it goes through periods ending at the end of January. So many of those cost reports are delayed for a few months before they're actually filed. So as far as going through that exercise, it's good to go through that now and get that information together. But depending on when you actually file your cost report, that's going to be your date for getting that in. Hopefully that helps. That's all the questions we have in the queue. Let's stay on if there's any others. Great questions, because I didn't go too much into the penalties piece, but that's good to know. I mean, there's a lot of concern out there related to the penalties, or I say not concern, but it's more so questions on what exactly that means, because again, we do have some facilities that want to be more reactive to publishing their information. Another piece that I would have you take back to compliance and legal is that there's a myth out there that Medicare is going to force you, the hospitals, to put yourself in harm's way from a legal standpoint with your payers, as far as feeling that if you go ahead January 1 and display those charges, that the payer can come back and sue you. That's not necessarily true. Federal rule and many of your contract terms, and this is something, again, go back to your legal department and discuss, as many of the payer contracts will indicate their want for you to not display or discuss their rates, but it also says that you have to follow federal mandate. So this is a federal mandate. This is a requirement. It's not just an executive order. It's in the federal rule. So having to comply with that is a requirement and should, I hate to use better words, trump the rule on their payer contract terms. So where the federal judges have come in to say it's really not protected under the First Amendment rights, is that information related to what you are contracted with and allowed comes out in a way public back to your patients when they get a remittance advice. So it's not really secret. It may be secret to the general public, but it's not truly secret for the purposes of trade secrets. And that's how they've been ruling on those pieces. So they're not ready to give way. Also, there's certain states that do not allow for the non-disclosure agreements and gag clauses to be provided based on where you're located in your payer contract terms. So again, that's something to take back to legal. You may be included in one of those states. So even if it's in the contract terms, again, wouldn't apply in a certain circumstance. So those folks that are hiding behind, the piece of the payer may potentially sue us, may find out later that that's not necessarily the case, and you don't want to be hit with compliance review later down the road. So where this really is going to open up some opportunity for those that are kind of late to the game is really start to look at when you're looking at the value of compliance, you still have a chance as you're lining those pieces up. One of the bigger concerns that we had early on, we started talking about price transparency at this level before COVID, when we were really going to have a little bit more time, maybe a little bit more strategy focused around this, was saving ourselves from the media is concerned. They're waiting for this information to come out so they can compare hospitals and try to understand why would you charge 20 times over your highest negotiated payer and your cash pay discount. They're going to start scrutinizing it. So put different goggles on, look at it from different lens, and see if it's not too late to take some opportunities to maybe reassess your pricing, your basic business rules related to your pricing. So as a more complicated procedure is priced, it's going to reflect that. We're going to have an intensity type factor related. A bilateral procedure should cost more than a unilateral. Just making sure that it makes sense. So it's not just transparent. We have a webpage here if you want to see our perspective on it. It's more that rational pricing approach. Does it just make sense? Can you defend it? Can you explain why something's priced the way it is? That's going to be the next step for many of us once we get through this compliance mandate. If we can't do it simultaneously along the way, is to sit back and look at our pricing and our charging methodology and see if it makes the most sense for our consumers. If there's no other questions, I think that's probably all we have. I did see there was a question related to getting copies of the slides. Looks like that'll be available, or they're here, I believe, as well. If our moderator wants to give it, if you can give them instructions on how to get a copy of the presentation, and certainly if there's anything I've mentioned along the way that you want to link to, or have any other particular questions that come out of this, as you may share this with other folks in your facility, please feel free to reach out. I'm very easy to get a hold of. We'll respond to you as quickly as I can, and more than happy to share information. I put a lot of information out there on LinkedIn. We're constantly changing our price transparency webpage to stay up with our pace towards our compliance date, and revamping some different tools that hopefully you may find helpful.
Okay, thank you. Yes, the presentation is available to download under the Materials tab. So the attendees can access materials on their end and download the presentation. So on behalf of AAHAM, we'd like to thank everyone for joining us today, and a big thank you to Caroline for an excellent presentation. I'd now like to direct your attention to the survey that I have just brought up to your screen. We would appreciate if everyone could take a moment to fill out this brief survey. AAHAM does appreciate your feedback. This concludes today's session. To end, you may simply hang up or close your browser. Have a great day.